The world's come to expect great things from UC Davis. The bold, the daring, the big ideas that do more than address today. They solve for tomorrow. As we look forward, we look to you. We're asking you to think bigger than what's possible of an individual, to make a greater difference with us. Expect greater from UC Davis for the world.
Hello everyone, I'm Chancellor Gary May. I'm excited to welcome you to another great installment of our Plugged In event series. At UC Davis, we understand that we are a part of a bigger community. There's perhaps no other time where we realize just how strong the bonds of our community were than during the COVID-19 pandemic. As other universities attempted to isolate themselves within the borders of their campuses, UC Davis took a different and bolder approach. We opened up our campus to the community so we could fight coronavirus together. During the height of the pandemic, we partnered with the City of Davis to launch the Healthy Davis Together program. The goal of this joint initiative is to prevent the spread of COVID-19 while also facilitating a return to regular city and university activities. Through the program, we made COVID-19 testing accessible and free to all residents in the City of Davis. It has since expanded to include the communities surrounding UC Davis. This initiative is the most ambitious program of its kind. It has received nationwide attention and acclaim, including a feature in the New York Times, showing the nation once again how UC Davis is creating innovative solutions to the world's most urgent problems. Today, our moderator, Provost Mary Krogan, will guide our expert panel through a discussion of the distinctly UC Davis approach to the COVID pandemic. That includes creating an in-house rapid saliva test, community testing and vaccine programs, and preventing the next pandemic. Sustaining healthier communities is a cornerstone of our Expect Greater campaign. This means we are raising the bar for well-being by pursuing solutions that nourish communities and give people equitable access to the resources they need to thrive, whether that be through addressing violence, homelessness, or disease. At UC Davis, this holistic approach to finding answers to the world's most pressing problems not only pushes the boundaries of what's possible, but it enables us to actively make a difference in the lives of our communities and beyond. I know you'll find today's discussion interesting and inspiring.
Good afternoon, everyone. I am Mary Krogan, Provost and Executive Vice Chancellor here at UC Davis. I want to welcome you and thank you for participating in this important discussion of COVID-19 solutions. I became Provost and Executive Vice Chancellor on July 1st, 2020. As I'm sure you can imagine, this was quite an interesting time to become the university's #2 leader and Chief Academic Officer. But as a proud Aggie alumna, member of an Aggie family, and an Aggie parent, there is no job I would rather have. Over the past year, I have been honored to help guide UC Davis through the COVID-19 crisis, as well as ensure that the university we love continues to benefit the people of California and the world. One of the many benefits of being provost is that it gives you a front row seat to so many extraordinary achievements made by members of our Davis community, achievements that span the disciplinary spectrum. So I am delighted to be here with you today to highlight achievements made over the past year under highly challenging conditions that have helped us and others to effectively respond to the pandemic. First, a few notes to prepare you for what's to come. The university has been hosting this series of plugged-in events for you, the valued supporters of UC Davis, so we can stay connected even while practicing social distancing. We also want to make sure you know about some of the many exciting things currently happening at UC Davis. During today's event, our expert panel will discuss the variety of ways they are working to sustain healthier communities and also the different areas of innovation in which they play a leading role. After you've seen the presentations of all the panelists, I will return to moderate a live Q&A session. For those of you who submitted a question before the webinar, thank you. If you have yet to submit a question, please don't worry. You will have the opportunity to do so throughout the event. Just type your question in the Q&A feature at the bottom of your screen. If you have a question for a particular panelist, please be sure to indicate that. Lastly, after the Q&A, there will be a short poll that we would like you to complete. Doing so will help us plan future events that focus on topics of greatest interest to you. With that, let us get started. It is my sincere pleasure to introduce our first expert, Dr. Brad Pollock, who serves as Associate Dean for Public Health Sciences and leader of the Healthy Davis Together initiative. Brad?
Thank you, Provost Krogan. I'm going to actually present a little bit about the public health sciences aspect of how UC Davis has dealt with the pandemic. So I'm Brad Pollock. I'm actually the chairman and a professor in the Department of Public Health Sciences in the UC Davis School of Medicine. So as you're going to hear throughout this session today, there's really been an important reliance on technology to address aspects of the pandemic. And that's not to be undercut at all. The technology that's come forward for this pandemic has been nothing short of amazing. And this would include some of the epidemiologic modeling and forecasting, and in particular, you'll hear about predictive modeling, which really does have the potential to completely avoid or mitigate an epidemic. In addition, there's been, I think, a very clever application here of genomic testing that was really used originally for ag biotech, looking at plant pathogens, but applying this now to the SARS-CoV-2 virus, in particular for the pandemic. And that's been an incredible tool for helping us understand what the patterns are of spread of the disease in the community and also on the campus. In addition to that, we have an emerging technology in wastewater monitoring, where we're looking at output from sewers, for example, and trying to detect trace levels of virus in the wastewater. That's been a technology deployed on a lot of other college campuses around the country, where you're monitoring individual dorm buildings, for example. It's another check on seeing whether there's infection present in those buildings. It's been used also at the city level, at treatment plant levels. One of the things that we've done that's been pretty innovative here has been using this at the sub-sewer shed level. That is, where we have monitoring stations set up throughout the whole city of Davis, for example, and we're able to detect virus at the neighborhood level, which gives us an idea about how to intervene. In addition to wastewater monitoring, I think without question, one of the absolutely miraculous things has been the vaccine development, to have a viable vaccine available in less than a year, and actually have 3 vaccines that have been approved for emergency use authorization here in the United States in less than a year is nothing short of amazing. Again, the technology for doing messenger RNA vaccine development goes back about 10 years ago, but the technology has really played an important role there. But I have to say that all of that technology is good, but the other factor that's really important is really talking about the people aspects here. It turns out that all the technology in the world is not going to solve the problem of how we prevent or mitigate actual epidemics. And so it comes down to things like, how do you get people to actually get tested? That's not a minor challenge. It's been a constant struggle to improve the testing rates over time. How do you get people to adhere to what we know are proven non-pharmaceutical interventions? These are things like masking, social distancing, and so on. We know that's been a constant struggle over the last year and a quarter. And so those are important people factors as well that really mitigate or can regulate what happens with the shape of an epidemic. And lastly, now we're dealing with the problem, how do you get people vaccinated? How do you get people to agree to be vaccinated? We've done a very good job, but we still are lagging behind. There are pockets of people that are not vaccinated, partially because of issues of access, but also partially because of behavioral issues, and trying to impart the appropriate knowledge to get people to kind of conform to what we know are going to be the safest thing. So it does come down to people as being one of the united issues here, where the technology comes into play with things like health behaviors. So in Davis, we actually started the Healthy Davis Together project back in June. We started the planning in June of 2020. And the idea here was to take the best known COVID-19 interventions and apply them all at once to an entire community, not just the university, but to go beyond that. We were combining epidemiologic infectious disease control along with health behavior change and interventions that will hopefully come together synergistically to reduce the spread of the virus. And the idea was also to extend the bubble of what we'd done on campus, where we were doing screening of every student starting back up last September, moving into the dorms, to extend our testing and other things that we're doing to control the pandemic out to the whole community. And that involved developing and strengthening partnerships with the university and the city of Davis, with Yolo County, and a broad set of community stakeholders. So the Healthy Davis Together project, in a nutshell, is designed to lower the burden of the infection in the Davis community, as well as to facilitate a gradual return to normal activities, regular activities. And of course, the reintegration of students last fall, and of course, this coming fall. In addition to that, we are looking to identify replicable and scalable applications that could be generalized to other communities. And lastly, what we will hope to do is to have a lasting infrastructure improvement so that our public health and the community health is going to be sustained beyond the pandemic here. And so far, the project's had some very big impacts. Now we've had a very big impact on looking at the epidemic a curve within the Davis community. It's been much lower than other surrounding areas and the state and California in general. We've also started looking now at the impact on economic activity, and we're assessing sort of what our compliance has been in terms of changing people's health behaviors. Davis, on average, has been much more adherent to the prescribed recommended levels of health behavior change that we needed to have here. And I think we've also built up community resilience. And we're now in the process of trying to disseminate our learnings, if you will, to other communities. Finally, as I said, we're working hard now to look at what elements that will be sustained beyond this. And in fact, that really gets to our next sets of talks. One of those, of course, is predictive modeling. And my colleague, John Mazet, who is the founding director of the One Health Institute in the UC Davis School of Veterinary Medicine, is going to be speaking next. Thank you.
Well, I'm so honored to be here and proud to let you know that UC Davis has been working in this field for more than a decade. And even a decade ago, we knew that there were on the order of 3 new emerging infectious diseases of people every single year that were causing epidemics and sometimes pandemics. Now today, that estimate has gone up to 5 new infectious diseases per year that almost all spill over from wildlife hosts into people or into domestic animals that we live with and eat to make us sick. And really what we need is we need to get ahead of the curve. We need to be looking at and understanding these pathogens before we're in the situation where we're locked down and having these horrible tragedies of millions of people dead and economies and social systems crashing down. So what we think we need to do is to really work to reduce these curves. So I mentioned getting ahead of the curve. What I mean as an epidemiologist is these are epidemic curves where we look at the number of cases as we go across time. Now the blue one is the domestic animals, and that's where pathogens can multiply, amplify, and become a big source of spillover to humans. But pathogens also can directly spill over from their wildlife hosts into humans. So what we have done with the help of the United States Agency for International Development is we've worked over here in this zoonotic pool, or the green area on this graphic, where animals have their normal viruses that probably don't make them sick because they've evolved with them, but they're available to spill over into livestock and amplify, and spill over then into people, or spill over into people directly. Now, if we can lower those curves, we need to start early. We can't jump in the middle or towards the end of an epidemic or pandemic and expect to have great results. We need to be over in that green section and really understand and model and identify where the highest risk areas are and what practices they are and reduce those. And then we need to have laboratories ready for early detection. And that will allow us to jump in for control early. So before the pandemic, as I mentioned, for a decade, we had been working in that exact area. And we were able to identify about 1,200 novel viruses from epidemic and pandemic families of viruses. So really about 900 of those were brand new to science, and some of the others were already known, but we were finding them in new places, new risk interfaces, and new species. And we prepared their countries where we were working to be ready for those pathogens. We also developed all of the protocols so that other countries can do this same work. And now, because this didn't get handled before the pandemic, it will be a big focus and a huge gift that UC Davis is giving to the world to understand what's out there and how to identify it. And then we can be much better at controlling it so we never get into this situation. In addition, we were able to train almost 7,000 people around the world to do this work, and we equipped and helped to build the capacity in 60 laboratories. The result, we were able to actually have our teams who were no longer funded by the project jump in all of the countries where they were working and help and join things like their national task forces. Our laboratories that were our partners in this project that identified viruses and trained people and created the protocols to help make sure this will never happen again, they were the first to actually identify introduced cases into their countries in places like Nepal, Thailand, Cambodia. In other places like Tanzania, they were the first to rule out cases even before there was a preferred diagnostic method and before we had the full sequence of the virus. They were able to use our protocols to say this person can go home, isn't sick. And in other places where they were finding the cases, they allowed their countries to jump in and really get their public health systems integrated and going even earlier than anywhere else in the world. So they were able to start their control operations early, just as I mentioned is so critical. In other places like Rwanda, our partners that worked on the project were the first people to ever publish on a coronavirus. And so they were clearly the world's experts and helped with disease control at airports and elsewhere. Here at home, our laboratory helped their laboratories with quality control and assurance. And for some of the countries where we worked, we were testing too, because they had so many cases. We weren't able to test for our own country in our lab because it was a research lab, but we were able to safely deactivate the samples, import them, and help their countries get going. Now, I hope our lessons learned will be very much used all around the world. In fact, the G7 met this week and is interested in using our foundational materials to drive change for the world. But in other places, we also want them to continue that work, and we're so proud to be having been of assistance. We found the species and family of the hosts that are most likely the natural reservoir of this pathogen, among other things. And you're going to hear more about how all of this work is helping Davis, helping California, helping our nation, and helping the world. And with that, I'd like to introduce you to the next speaker, distinguished Professor Richard Mifflemore, who's the director of the UC Davis Genome Center, and he's going to talk about our rapid saliva test.
Well, thank you for joining us today. What I want to do is to give a very brief outline of how we deployed a rapid testing program for the campus and city of Davis, and are now doing detection of variants of concern. One of the big sort of things here is that this has been a tremendous team effort, and I can only just touch on some of the things we did, but many, many people have been involved. But so our goal was to provide rapid, inexpensive, high throughput testing of SARS-CoV-2. And to monitor variants of concern using technology that was routinely deployed in the ag biotech sector. So we are a temporary pop-up lab that is an extension of the existing Student Health Clear certified lab. We've done this in the Genome Center, the DNA Technology Core. And if you want to know more about what actually goes on behind the scenes, there's a link to a very good video that Communications put together. What we did was, I knew back in April that there was technology in the ag biotech sector that was capable of generating millions of data points a day, orders of magnitude higher throughput than was conventionally in the medical world for testing. And so we reached out to contacts in ag biotech, and they put us in contact with LGC that makes this technology. And together, in a very short period of time, we rolled out the testing. So the technology is relatively straightforward. The bigger challenge actually was collecting samples. And what you see here is the taking over of the ARC 4 basketball courts, where we can collect saliva, and we can actually collect, let's say, 32,000 samples a week. It's fast, it's quick, and you know, we've had very, very high compliance of the student community. We now return our data quickly. About a third of the samples get returned the same day, and then within 24 hours or so, we have returned over 95% of the record. Then we actually take all our positives and we run a second set of technologies, second set of assays to determine whether it's a variant of concern. And as you know, there's a lot of focus in the news right now of how the virus has changed. Now, viral evolution is inevitable. We're going to see it, but most changes are inconsequential, but a few of them confer a selective advantage on the host. And what's been happening so far is there's been selection for increased transmissibility. And you see the new strains in the news, particularly what's now called Delta, that was first identified in India. The rollout of vaccines represents very steep selection pressure for changes in the virus to render the vaccines less effective. And it's my feeling that an increase in virulence is probably inevitable. Some people predict that we'll have strains that will overcome the vaccines within 12 months. So what we need to do is try and avoid a boom and bust cycle. And this is going to require very active monitoring for variants. And when a variant appears, we need to go in and do vigorous contact tracing to make sure it doesn't spread. Now, the equipment that we took from the ag biotech sector was actually originally designed for SNP genotyping, that is looking for changes in DNA of plant material. So it was relatively easy to develop assays for monitoring changes in the sequence of SARS-CoV-2. I say all our positives are currently genotype, and we put the results out to the county health within a few days of collection. This is much, much faster than relying on sequencing to achieve the same result. So stepping back, why have we been successful in this program? And I think I've put a number of bullet points here. One of the key things was that we had in place a high complexity, service-oriented facility in the form of the Genome Center, and we could repurpose that and provide experienced personnel to carry out the tests. We didn't accept the status quo or the conventional wisdom. Everyone thought you had to use MP swabs. That requires shoving something forcibly up to the back of your nose. You're not going to get people to repeat testing like that. So we chose saliva rather than swabs. We accessed existing experience in academic and commercial entities. And we were prepared to do something we really hadn't done before, which is really high throughput testing. Another key thing actually was I recruited lieutenants that could be relied upon to get things done. And these aren't faculty. Faculty are too busy to do this kind of thing. So we had senior experienced staff that really stepped up. And you assign defined areas of responsibility. But we're high throughput, and I knew what the technology could do, but I really wanted to manage expectations to match deliverables so we could actually work on. There was close integration between the campus, the City of Davis, and county efforts we already heard about. And importantly also, we had a totally committed administration. They really made things happen. Last point is this was a massive team effort from all across campus. I'm not going to go into the different sections, but just to acknowledge many different people were involved, from the people in the testing lab, the kiosks, and administration, purchasing, HR, health and safety, communications, and of course in data management. This was really key to a successful rollout of testing that has kept the prevalence of COVID very low on the campus and the surrounding community. Well, thank you. That's my story. I'd like to introduce Michael Condren, who is the Chief Operating Officer, Ambulatory Care, UC Davis Health, and he's going to talk about the vaccine rollout in Sacramento.
Hi, I'm Mike Condren. I'm the Chief Operating Officer for Ambulatory Care at UC Davis Health. Thinking back to the beginning of the pandemic, we really went through many stages and have been at the forefront of the pandemic in many ways. What I'll describe required incredible teamwork across faculty and staff on the Davis campus and at UC Davis Health in Sacramento. The first phase was really ensuring the safety of our patients, employees, and students, securing the PPE, working with our supply chain partners to make sure our staff were safe, developing safe policies, installing physical barriers and social distancing rules in our waiting rooms and screening at our entrances, new visitor policies, making sure all of our patients are safe, making decisions on what kind of elective care could be deferred safely and what kind of care really needed to go forward without affecting patient outcomes adversely through a delay in care. And then just an incredible explosion of telemedicine. We went from delivering 100 visits with patients in our outpatient clinics a week via telemedicine to well over 1,000 per day. And it required incredible partnership across the clinical teams, IT, and our staff to make that happen so we could treat people at home safely. I'm pleased that work will continue as a standard of care going forward for many, many patients conveniently across UC Davis Health. Then we got into early treatment phase. We had the very first hospitalized patient in the nation who was identified as community transmitted COVID-19 back in February of 2020. We were one of the very first to use remdesivir as an early emergency use treatment for COVID-19 and have stayed on the forefront of clinical research, clinical trials for treatment and vaccination and care of patients with COVID-19. When we moved into the testing phase, as testing became available, we developed 5 drive-up test sites in Sacramento, Davis, Folsom, Elk Grove, and Roseville, navigating the weather of summer and winter and making sure that patients and community members across the community could get tested for COVID-19. We navigated supply chain challenges, both with the swabs to collect samples, the media kits to transport them, and the testing reagents needed in the lab to execute the test for COVID-19. A few examples of innovation: our Institute for Regenerative Cures, in partnership with the clinical teams at UC Davis Health, developed media kits and was able to supply us during times of shortage to be able to continue testing. And our innovation partners on campus developed 3D printed swabs that, should we have run out, we were ready to seek FDA approval and have our own manufacturing of 3D printed swabs. So a couple of examples of really great innovation and partnership. We also partnered with Sacramento County to get into nursing homes, behavioral health centers, to do testing of the most vulnerable in those congregated living facilities, and then also set up 10 community testing sites across the region in underserved areas that continue in operation today. So multiple additional efforts by our faculty, working with migrant farm workers through the Center of Reducing Health Disparities, working at homeless camps and shelters, and for other parts of our vulnerable population. We were involved in early treatments for COVID-19. We opened an infusion center for the emergency use monoclonal antibody therapy treatment, which has continued to be offered today. And then we really moved into vaccination, and that's the most recent phase, of course, since mid-December. We started with healthcare workers, but not just at UC Davis Health, partnering with Sacramento County to help vaccinate all of the unaffiliated medical practices, dental practices, ophthalmology practices, others that are not part of the big local health systems and didn't have easy access to the vaccine. Then we moved into patients and our community members, not just UC Davis Health patients, but widely across the community. I'm pleased to say that we've vaccinated well over 150,000 doses to date and continue to do so every day. We've operated weekly clinics in Oak Park, at City Church in St. Paul's, and in South Sacramento at La Familia, focused on vulnerable populations, working closely with our community-based leaders, and really partnered well with the public health leaders at Sacramento County and Yolo County. And our faculty and nurses have been engaged in numerous initiatives with, again, homeless, farm workers, and really partnering with the county at multiple pop-up clinics across the region in areas that may have barriers to accessing the vaccine. So in summary, the response has really been a tremendous team effort across UC Davis Health, our county public health leaders, our community partners, and our local health systems. I'm very proud of the part that we served at UC Davis and UC Davis Health in supporting our community through the pandemic.
Thank you, Mike, and thank you to all of our panelists for sharing how your important work is changing lives and leading our community towards a healthier future. Greatly appreciated. Let's now move on to our Q&A segment. I'd like to invite all of our speakers to come on screen so we can begin our discussion. To let you know, we had several questions submitted before this event, so we'll dive into those first, and whenever possible, I will combine them with new questions that have been entered into the Q&A. So when they're related, I'll put them together, and then we'll look at the separate questions that have been entered into the Q&A portion. So my first question I'll pose here is to Richard. With the saliva test, what markers are you looking for, and how does that relate to what other tests check on?
Great, good question. You can broadly categorize tests into two types of tests. One of those are the ones that look for particular sequences, RNA sequences using PCR, or the other ones are the so-called antigen tests that look for the proteins that are made by the virus, particularly those on the outside. Now, we're running a PCR-based test. So what it does, it takes it works from the RNA, and it amplifies up particular regions of the virus. And in our case, we work with the CDC approved test, the first one that came out, and we look for two targets, the so-called N1 and N2. This buffers us a little bit against variants in the virus, so that if there are changes that prevented the PCR reaction working with one, we'll still get the other one. So we're fairly robust against change. But we look at two targets. Other packages will look at three targets or one target, but many of them look at a similar breadth of sequences in the virus.
Wonderful, thank you, Richard. And the next question is for Jana. What new emphases and commitments to virus monitoring in both wildlife and livestock were prompted by the pandemic?
Well, that's a great question. And thankfully, when we think about livestock, primarily we aren't seeing infection. This virus, SARS coronavirus 2, is a species jumper, can jump from species to species, but we're not seeing a huge impact on our livestock industry. In fact, most of the surveillance for food systems has been more around the meat packing plants and the food processing because of people coming into work who might have asymptomatic infections, which are Healthy Davis Together. If that kind of program was everywhere, it would be incredibly helpful for those issues as well. But we do not believe, and we have not seen that this virus can be transmitted through food or packaging of food. So I think we're in really good shape there. We are seeing the agricultural industry stepping up and doing unique and innovative kind of testing like wastewater testing. And you're probably hearing about municipalities and hospitals and others doing wastewater testing. So I think that's helped a lot, but there isn't really the evidence for our traditional livestock species to increase surveillance there yet, but it's it's being watched. And there's an organization called the OIE, which is like the WHO for animal health. Now, wildlife is a different story. There are huge plans to see the kind of work that I talked about in the video done on a much larger scale all over the world to identify these viruses before they make us sick and understand what we're doing to put ourselves at risk. Now, those can't start quite yet. And while in some places it's safer, there's higher vaccination rates, you may see more work starting early. But for the most part, the wildlife health community has put a voluntary moratorium on itself because we want to make sure we control all of the infections in people so that people don't accidentally infect wildlife and set up potential sources for infection, because it is such a jumper and we don't know the full host range.
Thank you very much. This question is probably best addressed to me as provost, because it's a little broader than just COVID. How are UC Davis Health in the UC Davis campus helping the international students and researchers to return back to campus? Well, this actually is a multi-pronged approach. The first is that the University of California has been encouraging the State Department at the national level to reopen consulates and work with our international counterparts to process visas for international students, researchers, and faculty. The visa applications and processing were largely shut down completely during the pandemic, and people were truly stuck in other countries and unable to travel abroad. And that was above and beyond any other kind of travel restrictions that might have been in place. Fortunately, this is starting to ease up. Literally right now, with every passing week, we're seeing more and more of our international students, faculty, and staff able to return or to come to the United States for the first time. So that has helped considerably. But also when they arrive, they undergo virtually immediate asymptomatic testing using the wonderful saliva test that Dr. Mifflemore just spoke of. So we go through that process. And then if they've not had an opportunity to become fully vaccinated in their home country, we will vaccinate them on campus. Or if they would like to get revaccinated, if they've already been vaccinated elsewhere, but want to have Pfizer or Moderna or one of the vaccines that we're using in the United States, we're also very happy to do that. Some countries, when those people enter into the United States, they're required to quarantine for 10 days, possibly as many as 14 days. And we're also providing quarantine housing and actually isolation housing as well if they're already infected with COVID. So I think the support services have actually been quite strong. And throughout this time, our Office of Global Affairs has been working closely with all of our international students and researchers to ensure that we could provide remotely the services that they needed, the courses they needed, the research opportunities that they needed before they could return to campus. So it's been pretty comprehensive. I'll now turn to Brad. The question is, and I will have a follow-up question from the Q&A. The first question is, I learned about Healthy Davis Together after reading the New York Times article. Wondered if UC Davis is an example for other universities and other college towns.
I'm unmuted now, hopefully. Yes, it's a great question. We thought long and hard about this. Of course, like other communities and other universities, we were dealing with the immediate problems that started us here. Hold on, I'm sorry. For some reason, my video got switched off. There we go. When we were confronted with the pandemic, of course, we were working on solutions locally here, but we had in mind all along being able to develop infrastructure and approaches that would be generalizable. So the answer is yes. If you were to go back and replicate the pandemic and you put into place the things that we did in Davis, I think they certainly would play quite well in other university communities. But more than that, some of those are not going to be generalizable. And there, of course, are a variety of different kinds of communities, not necessarily ones that are college towns like Davis. So we had in mind that each of the components that we worked on would have different degrees of generalizability. So I think a couple of things, the lessons that we learned here, I think that are important are, number one, it's partnering with the appropriate folks. So if you're at university, there's oftentimes a town and gown issue, which is how do we get along with our surrounding cities? And I think what we did on this project was we sat down with the city from the very, very initiation of the concept for this project. And I think that's a lesson that's learned from us. I think that was critical in getting us to where we're at right now. The other things that we did is we engaged a wide range of stakeholders, again, in the planning for the project as well as the execution. And that includes a variety of community-based organizations. I'll point out that while we started this project before there were vaccines, we even had a module that we described a year ago for what we were going to do with vaccination. And the vaccination approach that we took, again, very generalizable to other communities. We focused on not replacing the large healthcare provider organizations like Kaiser and Dignity and Sutter, where they were going to vaccinate their populations, but rather looked at where the harder to reach individuals were. And as an example, we worked with a county of the Yolo County to target the migrant farm workers and go into their camps. So a lot of our efforts have been sort of dealing with special populations, trying to take clever approaches there. So while, again, it's hard to imagine lifting the entire project over to another community, these individual aspects, I think, are very generalizable, very useful for other places.
Thank you so much, Brad. And the sort of related question to Healthy Davis Together that came in the Q&A, would you consider extending the Davis community testing on a voluntary basis to detect asymptomatic COVID in the community that might have escaped vaccination protection?
Yeah, well, I will say, number one, we're having the challenge of keeping our Davis community tested. Just say that the CDC guidelines that came out over the last couple of months said for fully vaccinated individuals, don't get tested unless you're symptomatic. And we really take exception to that. We think that's a very important part of surveilling what's going on in the population. And certainly extending the bubble beyond Davis is an important consideration. We have, in fact, in the second phase of our project now moved into the K through 12 schools throughout all of Yolo County. And that's a very important move, particularly because the young kids can't get vaccinated yet. So we saw it extremely important as doing testing now, extending that out beyond the confines of Davis. We can't do the whole world or the whole state, but I think the idea of doing that kind of targeted asymptomatic testing is going to be critical. And also, of course, we're waiting for really a good sentinel surveillance monitoring scheme now. And I think that's going to be doing probabilistic sampling for individuals for testing, as well as a combination with wastewater monitoring, which is another adjunct, which we think will help. But it certainly is important to be looking beyond Davis. And we have been doing that formally now for the last couple months.
Great, thank you, Brad. Mike, this question is for you. Is anyone at UC Davis looking at long hauler COVID infections? So what happens to people in the long term, or those people where the symptoms continue for an extended period?
Yeah, thank you, Provost. We have developed a clinic specifically to support the needs of our patients who are experiencing symptoms of COVID long hauler syndrome. The clinic is located in Sacramento at our Pulmonary Specialty Medicine Clinic, located on J Street. It's led by Dr. Mark Abdalovich, professor of pulmonary medicine. The patient experience starts with an initial visit to gather information and to develop an individualized care plan. The clinic is located within Pulmonary Services, who collaborates then with many specialties to support each patient: cardiology, neurology, rheumatology, gastroenterology, and many others, including social services, to make sure the needs of each patient are met. I will place into the chat the contact information for the Pulmonary Medicine Clinic in case folks want to get more information directly from the clinic, and also for the Physician Referral Center in case they want to work with their treating physician for a referral to this clinic.
Great, thanks so much, Mike, especially for putting that link in there. The next question is it necessary to get tested weekly after being fully vaccinated? And I will respond to this. If Brad would like to add anything, he is more than welcome to. We are both epidemiologists by training. A silver lining to the pandemic is no longer having to tell people what that field of study is. I'm sure Brad had the same experience I did, that nobody ever understood that before the pandemic. And actually, Sean is an epidemiologist.
Yes, yeah.
Well, you have three of us, a monopoly. So is it necessary to get tested weekly after being fully vaccinated? I will tell you from an epidemiologic perspective and personal perspective, I am fully vaccinated and I intend to still get tested on a regular basis. I hope it continues to be weekly. That's what we originally have had in place for the campus. But and the reason for that is that you can have breakthrough infection. If you have breakthrough infection, even though it's rare, it's less likely that you're going to have symptoms when you've been fully vaccinated. And as a result, you might be capable of infecting other people and not taking any precautions because you don't have symptoms and you're not aware that you're infected. So I will also continue to wear a mask in many circumstances, even though I am fully vaccinated, and that's no longer required on campus or per CDC guidelines. Having said that, to continue testing on a very large scale basis for the campus and quite honestly for the city of Davis and the Yolo County into the fall is logistically challenging. Richard and his team did an incredible job of scaling up the saliva testing to be able to just keep adding and adding additional groups that we added into that. But this fall, we will return to 100% in-person instruction, research, and service. Of course, our patient care always stayed at 100%. But returning all of our students to campus and so forth, whereas right now we have between 40 and 50% of our students in the community. If we continued the weekly mandatory testing, it's a bit of an exaggeration, but it could literally be all that we would be doing this fall is lining up to get tested, undergoing the process and having very little time to do our other work. So given it is rare to have breakthrough infections, it would be ideal to do so, but the logistics and the expense, quite honestly, means that we're going to require testing every 4 days for people who've not been vaccinated. And the only people who will not be vaccinated on our campus, at least, are those with a medical exemption or a religious belief exemption. And the expectation is therefore that the people who are fully vaccinated have an option to participate in testing. And as I said, on a personal note, that's what I expect to continue to do.
Yeah, Mary, can I just add one thing? So I agree with you. I'm in the same boat. I've been getting tested regularly and I've been vaccinated since February. So I think it does contribute. It's important. And I do also recognize the practical limitations of not being able to do this. Scaling up that large will be very, very problematic. I think there's one other reason for doing continued surveillance, which is trying to look at the effect of the change in the variants over time. And that's something, again, we've really done a great job with. If we weren't testing, and including fully vaccinated individuals, we'll have no idea, I think, or a very poor idea about the Delta variant becoming growing in our community. The fact that the beta and gamma strains came to die in Davis, they were there and then they went away. But doing that sort of assessment over time is really important to get an idea of what's going on with the virus in the population. So I think we're going to have to strike a right balance. The way this is normally done is you'll develop some sampling schemes where you're not sampling everybody, but you'll have a probabilistic sampling scheme that gives us a good handle on what's going on in the population without having to test everybody. It may be a 10 or 15% sample of individuals. And I know the CDC right now is just gearing up and starting to focus now on developing those sentinel surveillance monitoring schemes so that we don't have to test absolutely everybody all the time. But I think that's still kind of a question mark right now. And of course, the other issue is if we, unfortunately, if a community does have an outbreak, that changes the whole algorithm, right? Then you got to go in and do a lot more testing just to be able to handle that outbreak. But it'll be a challenge for us, and I hope that the wastewater monitoring will be a nice supplement where you can test a whole community without having to bring people in. That is a way of getting a handle on it. We've had many weeks now in Davis where there's been no signal in the wastewater. And that is a pretty good indication that the disease is under very good control. But that has to be monitored very often and very carefully to make sure that's still the case.
Thank you, Brett.
Can I jump in at the end of that? So thinking as an evolutionary geneticist, I'm not a card-carrying epidemiologist, but I've been actually studying pandemics for many years on the plant side. Changes are occurring all the time in the virus. Most of those changes are either inconsequential or deleterious, but a few of them confer an advantage. And if there's a selection pressure, that variant will increase. And to date, the major selection pressure has been for increased infectivity. And you've seen increased infectivity occur multiple times using similar changes in the virus. It happened in England, it happened in South Africa, it happened in Brazil, and then it happened in India. So you get this convergence. Now, I couldn't design a better selection experiment than the one that's currently going on in the US, where you have a very steep selection pressure called vaccinated individuals, yet you still have a large number of unvaccinated individuals that are infected, continually challenging that selection barrier. And I think it is probably only a matter of time before we have variants with considerably, where the vaccines are considerably less effective. And so it's incredibly important to continue monitoring. And just in the recent weeks, we have had asymptomatic individuals come through the testing program, which are, for those aficionados, the CQ values of 12 or 14. That means that these individuals have somewhere around 5 to 7 million viral particles per microliter, the size of a pinhead. Asymptomatic, right? So the selection pressure is for the virus actually to be asymptomatic. The virus is not trying to kill you, right? It's trying to spread. So if it can be highly infectious, asymptomatic, and then overcome the vaccines, that's your designer virus. So it's incredibly important that we continue to monitor asymptomatic individuals. And I would encourage people who have been in a high-risk situation, let's say a large gathering where many people and maybe themselves have been unmasked, or travel from a region of high prevalence, like if they've come back from Latin America or India, or they have in their household someone that's just come in from Latin America or India. So it'd be really socially responsible that if you've been in a high-risk situation, please get tested.
Absolutely. Two related questions that we received. One was from a UC Davis employee who said that they went to sign up for their appointment for their asymptomatic testing, and they received an automatic message saying because they were fully vaccinated, it was not required. That is true. That new public health policy went into effect this past week. And actually, there was a mailing out to the entire campus on Friday about that. So you might check your email for all the changes in our standards around public health guidelines there. But you are still welcome to do the asymptomatic saliva testing on the Davis campus or the Sacramento campus, as you so choose. And I think Richard's advice there, if you've had any contact with anyone infected or been in any high-risk situation, I'm just timeliness, I'm going to say you go to a 4th of July party. My recommendation would be get tested before, have a negative test before you go to that event, and get tested twice in the week afterwards to make sure you're not coming back infected to other activities. And someone also asked in the questions, what am I, Mary Krogan, personally going to do around testing and mask wearing? I'm going to wait till the pandemic's done. And that's going to be take another year plus. It could be 2 to 3 years. So my intent, and probably long-term in my life, will be to, when I'm in higher risk situations for transmission of any kind of virus, like flus, I'll probably more likely wear a mask. Whereas quite honestly, I used to think that was kind of hilarious to board a plane and see somebody enter the plane with a mask on. I would say now I'm a believer and will take those actions myself going forward. Okay, Richard, the two-part question for you, very related to what we just talked about. Does the COVID saliva test detect the Delta variant? And what are the plans for dealing with new strains of COVID? And I know you just addressed this in part, but I'll let you have a little more time on that.
Yeah, thank you. So all positive samples that come through, we, well, the technology we developed for the test was actually developed for detecting SNP variants, DNA variants in plant materials and high throughput. So it was a very logical, very easy step to deploy that technology for detecting changes in the nucleotide sequence of the virus. The variant, there's been a lot of convergent evolution. So the same changes are occurring multiple times, as I said, into these super infectious strains. Now, it's a different combination of those that characterizes the variants. So actually the Delta variant already had a number of changes that we'd already seen in the other variants of concern. So we had the assays, we were already running them. It was just a different combination of changes. So yes, we have been able to detect the Delta variant. We first detected it, in fact, in late April. But I think because of early detection and very effective contact tracing, it didn't blow up. It just recently, we had 7 in one day on the 17th. It's very stochastic that what we see coming through. The other thing we're doing is actually when you get tested and Healthy Davis together using the Bionax Now cards, these are the positive individuals, we can actually take the swab that was used in that, extract the RNA, and we run the genotyping on them. And it's the same with the student health lab. So we are running both the asymptomatic and the positive samples from the symptomatic individuals. So we're really getting a pretty good picture of how many variants. Of course, it's a subsample of people in Healthy Davis, but as Brad alluded to, it's really important to monitor the school children. And anyone that's had a child in kindergarten knows that the young kids are a biological assay system, better than sewer monitoring. They will get what is around. So by monitoring the young school kids, we can actually get a pretty good feel, I think, too, of what variants are out there.
Wonderful. Thanks so much, Richard. Jonna, this is very specific question, but I think it's incredibly helpful given several of the questions that have been coming in. Do you believe that we will need a vaccine booster? And if so, when and how often?
Well, of course, we have to go where the science takes us. But so far, I think all experts agree that we are very likely to need a booster because we aren't getting the whole world and all of our communities fully vaccinated. So there are lots of vulnerable people still left in most communities in this country, less so than elsewhere because we've had better access to vaccine, but still we're seeing new little surges that I hope don't become big surges in response to the variants that we've just been talking about. And until we have this thing controlled, we're going to need boosters to continue to protect us. So I would like to make another plug that if you don't have some condition that prohibits you from reacting well to vaccines, I encourage you to get that vaccination, not just for yourself, but so that you can allow your community to let some of these guards down a bit. So we don't have as much need for the different public health measures that we're talking about today. So we know that the vaccines are lasting a decent amount of time, at least 6 months. It looks like longer, maybe even longer than natural infection immunity lasts, but not really staying as high as we want them to stay over the long term. We're waiting for these cohorts of early vaccinated individuals to show us when their vaccine starts to wane. But another positive thing about the boosters, especially with the mRNA vaccines, is that they can be manipulated very quickly to add the new strains. And so that protects you from the new strains that are coming as well, and protects the planet so that we don't see severe disease and that we can start to shut this thing down.
Great, thanks so much. And I'm going to pose this question first to Brad, and then I will let the others of you chime in if you'd like to. What would you say to those who are still not prepared to receive the vaccine, whether it's due to not trusting the government push, not having an FDA-approved vaccine, lack of knowledge of the long-term effects, etc.? There's a lot of unknowns, so how can you ensure its safety if being mandated? So I'll start with Brad, and then I think turn to Jana and then others.
Sure. I think the concept of vaccine hesitancy, why people are resisting, it's very complex. It's very individual. Every person themselves has a belief system, and it's not always the case that it's too new. Some people just have they're just dead set against having vaccines. Others, they can't quite amass the risk-benefit ratio here, which is a really important concept. And I know a lot of us have been doing in-service education for some of our employees that have, needed to get a little more education. The approaches that you take have to be sort of tailored to the individual. So if the question comes up, well, they're too new, we don't know much about this. Well, at this point now, we have 300 million doses that have been put into arms of Americans. It's not new. That's a lot of vaccine that's been administered. You've got that argument. The other argument is that you'll see an adverse event happen 5 years after you got vaccinated. There's never been a precedent at all, never a history that we've seen a vaccine that caused no reactions that you weren't able to categorize, and then 5 years later it shows up. It just hasn't happened that way. It is extremely unlikely to happen that way. Nonetheless, you can use these arguments, you can talk to people about this, but again, the belief systems are complex and it's difficult. So I try I've got 4 or 5 different things I try to talk to people about. Maybe one of those will resonate with an individual, maybe it won't. And it's a challenge. And we have the last point I'll say is the issues of misinformation and disinformation. Misinformation is when people are putting out information that's not correct. They probably believe it. I remember there was an incident about 2 months ago with a Placer County sheriff attributing a death that happened 5 hours after the Pfizer second dose was administered to somebody. He came out and said, this is a vaccine death. The coroner hadn't actually done the medical examination. And a couple of days later, the coroner said there's no attribution at all to the vaccine. Well, there was a front page headline in the Sacramento Bee about this issue. That's an example of misinformation where the sheriff truly believed that there was an attribution. Okay, that's very distinct from people that are putting out false information, purposely false information. For example, we're putting nanochips into the vaccine so we can monitor you and INS can pick you up and so on. So we have to overcome lots of challenges here. Some of them are the information challenges. Some of them are the education challenges for the individual. And again, it's getting hard to argue when you have 300 million doses delivered here. This is really new. I don't know much about it. I mean, this has never been in our history. This is unprecedented amount of vaccine that's already been delivered. So it's not the same argument you could have used back in January. I think, times change.
And I would argue that even then, the mRNA vaccine technology is over a decade old.
Yeah.
And so it is also misinformation when people present it as a new technology.
Yeah.
Jana.
Yeah, I'd just like to follow up on both your comments. Mary, as you said, it's not new. And I think some people confuse the acronym for emergency use authorization to be experimental use authorization. It is not experimental. The vaccines have gone through all of the processes. It's just that they were fast tracked. So nothing's really going to change between this emergency use authorization and full approval. The science is showing incredible benefits and wholly, very, very safe, especially for any kind of long-term effects. That said, as Brad so nicely articulated, communications and perceptions are very complex, and they are specific to the individual. So if you are in a family or a work situation or anything else where you are trying to convince someone that you care about to get vaccinated, I want to just recognize that that's difficult to do, because one piece of misinformation that validates a concern is incredibly powerful compared to all the scientific evidence that we could go over. So one thing that we probably should recognize is that there are some young people, especially young males, teenagers, that are having some side effects. And there's actually a CDC panel convened today, I believe, that is looking at that. The science and the evidence shows us that in those 300 million Americans that have been vaccinated, we only have 300 cases of that disease, that myocarditis, and that those numbers just are minuscule compared to the numbers of kids and people in the same demographics that are getting really serious diseases from COVID. Long haulers, as we talked about, hospitalization, severe disease that might not be able to be fully, remedied, death. And in this one definite, syndrome that we're seeing, that is not causing long-term problems. And it is scary, but it isn't a reason not to get vaccinated. And then finally, while we can't overcome, and we should be very respectful of people's reasons why they don't want to get vaccinated, I would say that I think the most powerful thing is that it's not just for you, it's about your community and your children and your grandparents. And those are the people that we really need to protect. If we allow new variants to get going and we allow a new surge, kids who can't get vaccinated look to be more susceptible to some of these variants for more severe consequences. We have to protect our kids. And that is one of the main reasons I see to get vaccinated.
Thank you so much, Jonna. And we've got basically time for maybe 1.5 questions left. And so I'm sorry to anybody where we were not able to get to your questions. This is a great audience who've posed very helpful insights. And for those of you who've asked how to get a copy of the recording, you very kindly said you want to share it with family, friends, and some of you have labeled them the non-believers. So thank you for that. And I've asked the staff to type in or come on line here and let us know, but I do know the recording will be available. So one last question here, and if my colleagues don't mind if I respond to it. It seems that some people probably felt they were unlikely to get sick with COVID. They may now be the same people who think they don't need the vaccine or they will get sick if they obtain it. And I think both Jonna and Brad have done a great job speaking to those issues. But perhaps we need help from a behavioral scientist, and is part of what they've asked in their question. And I think that's absolutely the case. One beauty of the work that we've done at UC Davis is bringing in people from multiple disciplines to address these issues. Sociology, other forms of behavioral science, anthropology, economics, political science, communications, and so forth. But I can tell you, I think one aspect that I've found personally effective, sorry to use myself again as an example, But in early March last year, before much was actually known in the United States about the pandemic, and we had a very small number of cases and closures had not taken place, I was flying back to be with my kids from their spring break on a jam-packed plane. And it turned out the young man I was seated next to was semi-conscious through the flight, should probably never have been allowed on the plane, running an extremely high fever. The steward on the plane and I were both trying to help take care of him during the entire flight. And turned out, of all things, he was returning from Italy and infected with the Italian, then what we call the Italian form of the COVID virus. And that was Wednesday, March 11th. And Friday night, I became gravely ill and spent the next 3 weeks at home, not hospitalized, but in and out of consciousness for 3 weeks. And I would say by day 3 or 4, and I don't mean this facetiously, although it will sound that, I went from, oh my God, I'm afraid I'm going to die, to, oh my God, I'm afraid I will not die from this. My head truly felt like it would explode, like my eyes would pop out of their sockets. It hurt to have sheets touch my skin. Everything in my entire body ached and hurt, like an 8 or 9 on a scale of 10 for pain throughout my body. I'm a person who's been incredibly healthy throughout my entire life. And I have never been in a position where I thought better to have this over with, except when I had COVID. And I had what was considered a moderate case, not a serious case. Like I said, never hospitalized. I would never in my life wish this on anyone. People who know me saw me during that time, which was a tiny, tiny group of people, mostly my kids and my partner, because I knew what it was and I was not going to infect others. They said the most bizarre thing is that I normally sleep 4 hours out of 24. And when I had COVID, cumulatively, I was only awake 4 hours out of 24, usually in 5 or 10 minute spots. So it was devastating to be that ill. And I tell that story, as personal as it is, to as many people as I possibly can, because trust me, you do not want to have COVID. You don't even want to have a minor form of it. And taking the risk of long-term symptoms, which thankfully I've not had, not getting vaccinated because you have any fear of the vaccine, trust me, there is nothing about that vaccine that could be as terrifying as actually being sick with COVID. I personally and completely and truly believe safer, better to be vaccinated. Great that we have the opportunity in Davis and on our Sacramento campus as well to do the asymptomatic testing. And I'm incredibly proud of the teamwork that it's taken across both campuses, across the city of Davis, and now truly all of Yolo County, to ensure that we could all be healthy by all doing our part and seeing that we're in this together. And truly, we are as interconnected as we could be. And when any one of us follows the guidelines that we should, it not only ensures our health, but those of everyone we love and care about, and even those we don't know who are around us. So personally, and as Provost and EVC of UC Davis, I want to thank everyone who's done their part to ensure that we've been healthy and safe. We've done incredible work, both at the campus through Healthy Davis Together and through UC Davis Health. Jonna's early work and decades of work with One Health and Predict, Richard Mifflemore, who, thank God, my first month here, talked me into doing the saliva testing and enabling them to do that important development work. Because remember, he did this from a plant-based test initially and converted it to humans. This was science at its best. So you've heard from people who've helped ensure we all stay healthy, and I want to thank them all and thank all of you for your contributions. I've got a just a minute more of comments I'm officially supposed to make. So let me return to that because that was on a much more personal note. So you have one final task we're going to ask of you. You should now see a short poll on your screen. We'd greatly appreciate it if you took a moment right now just to complete that. It's incredibly helpful for us to know what kind of programming you'd like in the future and what would be of greatest interest and help to you. So as you're completing the poll, again, I'd like to thank all the panelists speaking to us about your work, sharing your knowledge and your expertise. It's incredibly valuable to our entire community, and we get the opportunity to learn from those who know best. I'd also like to point out that all of our panelists represent UC Davis's commitment to outgrowing the expected by asking new questions, thinking creatively, daring to innovate, and persisting in the face of great challenges. They are finding new ways to help people. And as Chancellor May explained in his presentation, at UC Davis, we truly understand that we are part of a bigger community. And as a result, we strive to support the health and well-being of people everywhere, including our entire planet. Our university's deep commitment to addressing the world's most urgent problems, I love Jonna's expression, the most wicked problems, and the leadership role we are playing in that effort are things in which all faculty, students, staff, alumni, partners, and friends of UC Davis can take great pride. So keep filling out that poll if you haven't done so already. If you think you might like to support any of the research or programs discussed today by our panelists, or any of the other university projects or programs, you can learn more by contacting Tammy Spath, S-P-A-T-H. Her contact information should be on your screen now. And whatever it is that most interests or most inspires you, there is a way you can help support it. Last, but certainly not least, I want to express my sincere thanks to all of you. Those of you in our audience, both for joining us today and for your continuing support of various types of UC Davis. May you all remain healthy and safe, and we look forward to connecting with you again soon. I hope you all have a great day, and thank you.